I will unmute myself. Hello, welcome everybody to the Brown County Aging and Disability Resource Center's community presentation. We are a community coalition here in Brown County. My name is Sherry Mealy. I'm the Dementia Care Specialist up here in Brown County. And I chair the coalition as well as the education subcommittee of the coalition, where we work on initiatives and helping inform the community about dementia in various ways. And we have a series. So this is the first one of our series on dementia and cultures. And today we have Gina Green Harris, and she's going to introduce herself, and she's going to speak to us today on the Black community. Gina.
Okie dokie. So can everyone hear me? If you could just thumbs up, or I know you guys are all muted, hit your thumbs up button on the chat thing, something like that. And then, or fix your camera and kind of, yeah, for those of you who don't have your faces on, I totally get it. I am Gina Green Harris, and I want to, first of all, just say I'm excited to be here. Thank you so much for this invitation to actually have the opportunity to present to your team and committee and partners today around the issue of culture, equity, and equity in dementia care. And I want to say, so who am I? For those of you who may not have met me, I have been working in the field of Alzheimer's dementia and health equity for over, I don't know, I know I don't look as old as I do, so I'll just say maybe 13 years. How's that? But I've had the opportunity to work for the University of Wisconsin-Madison at the School of Medicine and Public Health and actually start our first program in the community that was focused on African Americans and dementia using an asset-based community development model. And so since that time of 2008, when we started, we've been able to build from a pilot program that focused on African Americans learning about dementia, being diagnosed better for and with dementia, and then offering care supportive services, and then finally helping families who are interested in engaging and enrolling in research. So that's been, it's a small portion of what I've been able to do, but through that work, we've gotten national recognition, we've written papers, and I serve on several national committees around how to build strong community programs through research that are effectively addressing Alzheimer's disease in specifically African American or Black and Brown communities. So today I'm going to start sharing my screen here because I get the opportunity, and I don't take it lightly, that I've been invited to present today to you all to address what I've called addressing Alzheimer's disease related dementia. And I'm going to talk a little bit about how sometimes systemic bias impacts our communities of color, and particularly today, I'm going to speak to the African American community. I'm going to minimize my screen only because, as most of us who are presenters know, our screens tend to get in the way of our slides. But because we're such an intimate group, I do encourage you, if you have questions, if I'm talking, I'd like this to maybe be even a dialogue, so that we don't have to wait to the end to answer questions. It's not about me getting through all of my slides as much as it is for me to really talk and share with you experiences from the African American community and get you involved in that discussion if you have questions, thoughts, or concerns. So with that, I'll go ahead and get the slide started. So today, what we're going to be looking at in this presentation, I will provide an overview of Alzheimer's disease and other related dementia, and how particularly, again, African Americans or communities of color are disproportionately affected. I'll talk about some chronic health issues and social determinants of health that are really important to understand, because those are critical factors for increasing risk of Alzheimer's disease and other related dementias in communities of color. And I'll talk a little bit about how systemic bias impacts patients' access to care, supportive services, as well as participation in research. And you may be wondering, why am I going to talk about research? But as you guys know, research is a critical tool that we have to use in order to address some of these challenges that we're facing if we're ever to hopefully to have a cure, intervention, or an appropriate treatment program for folks who are on the Alzheimer's journey. And then I'll share some real life strategies. I'll talk a little bit about our program at the end that has been effective in addressing these disparities. So I wanted to give a brief overview, since we are talking about African Americans today, just taking a basic look at where do we sit in this country when we think about how African American populations have grown over the last several years from 2000 to 2019, so almost 19, 20 years. And when we think about it, the African American population has grown from a rough of 36,200 to about million, to about 46.8 million people in this country are now considered Black, or what we call African American. And that's really important, partially important. I'll talk about this as I do my presentation. I want you to look at this not from the perspective of just Alzheimer's disease, but other diseases that we know are impacting our community at an alarming rate in Black communities. And this number is important when we're talking about access, when we're talking about treatment, when we're talking about just healthcare costs, because all of healthcare costs can actually be, when you think about employment, right? Most of our insurance is tied to employment. Then we think about transportation. How does transportation impact our ability to access different programs and services? And then how do we develop models for communities that are of color, and particularly African American and or our Latinx communities and our Asian communities? How do we build these programs? We know the numbers are climbing, so we need to understand we're going to have to think out of the box, because all of those can be attributed to health and health outcomes in some way. I'll talk more about that. So I wanted to bring it home also about Wisconsin's African American population. And so we've got, we're about 6.1% of the state population, which doesn't sound to be a lot, but when you think about it, it was initially 6.1%, but we increased to 9.7% since the 2000 census, right? In 2008, we were 6.1%. Now we're at 9.7%, and the numbers are projected to continue to grow. I want you to hone in for a second on that third bullet point, because we know Milwaukee County is the largest county that houses or is home to majority of African American communities. But there's this myth that African Americans only live in southeastern Wisconsin. Well, we primarily do, but I want you to see that Waukesha, which is southeastern, but I want you to see also when you think about Dane County is not necessarily Milwaukee, that's not southeastern, right? And then we've also got Rock County that also have African American large populations. And those are important because we often leave those out and we solely think about Milwaukee. We sometimes think about Racine and Kenosha, but we don't always think about Rock County and Dane County. Those folks in those communities also have care needs that we need to talk about, and how do we address those as well. And then of course, the aging population. And so the 13% of Wisconsin's population was 65% or 65 and older. And then 6% of that is African American population. Again, doesn't sound like a large number, but keep in mind those numbers will be growing. And this is solely our African American population. I did not put in our Latinx or Hispanic community as well, but those populations are growing as well. So when you think about the growth that we expect to see in our state and in our country, it's really important to understand how dementia and Alzheimer's disease plays a role, or how we need to really think about what are we going to do to make sure that we're caring for our loved ones in these ethnic groups around dementia and Alzheimer's disease, because we will eventually have to understand that they will be impacting our care systems at a greater level. But before I start talking solely about Alzheimer's disease, I do want to bring us home. And this, I like to use this conceptual map because it talks about the health of African Americans overall in the US. It takes us out of the spot of solely thinking about Alzheimer's disease, but thinking about the context of health for African Americans in the US. And you may say, why is that important, Gina? Well, that's important because you and I both know that Alzheimer's disease is not siloed. Alzheimer's disease has so many factors to it that the health of an individual actually can either stymie or stave off, or it can actually cause risk factors to increase for folks to develop the onset of Alzheimer's disease. So, research shows that there are people who have dementia in the brain, but it never, its symptoms don't show, they never show themselves. And that can be because of other health factors that are staving those things off. Or there's also times where people who are not the least healthiest, but actually demonstrate from our community earlier stages of Alzheimer's disease, and it exacerbates, or it goes fast, and it just causes damage quicker. So we know that overall health is really important when we think about, particularly in this case, African Americans and others in this country. Health overall is going to be important. And what I want to highlight in this schematic here is thinking about the social determinants of health inequities and the risk factors, and how those actually can be large contributors to folks who go on to develop a form of Alzheimer's disease and dementia. And quite frankly, when we think about this morbidity and mortality, we know that Alzheimer's disease is directly related to things such as heart disease and stroke and diabetes, as well as some cancers, right? But those are things that we know are high risk for Black communities. And so what I want us to think about is, why is that the case? How do we start addressing that? And how does that impact African Americans overall? Our health is really critical to where, how we end up in our journey in life. And we know that the data teaches us that what we do early on in life actually impacts us at the end of life. And particularly what we do in middle age actually has a strong impact of how we live the end years of our life, or the later years of our life. And so I wanted to just bring this model to you to think about, when you're thinking about, people say, well, African Americans are 2 times more likely. I want you to think about what you see in this diagram to help you internalize why some of this might be. Any questions about this so far? So what do you find, what impacts our health the most? Now, many of us may have seen this before, but I want to highlight a few things. We always bring to the argument to the table about healthcare and access to healthcare, quality of care through healthcare services, which is really important. But when we think about it, healthcare attributes 20% of our total overall health. What really impacts our health, quite frankly, are our health behaviors, which is our diet and exercise, our alcohol use, tobacco use. Those are controllable, and our sexual activity is also in there too. But the point is, those are controllable health behaviors, things we can do to control them. Physical environment, where we live, actually is really important. There's a study that was done that by Dr. Amy Kine and others that talks about where you grew up as a child can actually impact how you, if you develop dementia or other chronic illnesses. Physical environment is important, but the 40% we think about that we often can't see is the socioeconomic factors. Where we live, where we play, how we play, where we work, all of those are important when we're talking about our overall health, because we then can attribute things like stress. We can talk about things like how we eat, diet, nutrition. But when you go up to that social economic factor, how I eat is actually connected to where I work, how much money I'm bringing in. How I exercise is actually contributable to where I live and how safe it is where I live. Now, again, all of these, when we think about how do we lower our risk for dementia and Alzheimer's disease, those are things that we have to understand play a role in how we can do that. And when you think about it from a perspective of communities of color, African Americans may not live in walking neighborhoods. They may live in locations where there are not a lot of food spaces and healthy food choices. And so we have to think about the education level and as well as job status. Those are things that we need to consider when we're thinking about our health. And again, I want to talk about, I'm going to get to Alzheimer's and dementia, but I want you to think about, we can't only focus in one area and think Alzheimer's dementia only. We have to understand that it's more complex and that it is really about all of these factors that are contributing to why and how African Americans are impacted around Alzheimer's and dementia. So then I want to talk a little bit about, well, how is this word health equity coming along, right? We always, and I want to have a level definition of health equity when for how I'm explaining it through this presentation. So health equity is achieved when every person has the opportunity to attain his or her full health potential, and no one is disadvantaged from achieving this potential because of social position or socially determined circumstances. So that last slide I showed you, when we're talking about health equity, when we are able to make sure that everyone has full equitable opportunities and accesses to whether it's health care, to whether it's not based on how your income looks, but you still have access to good food, you have access to insurance. Those are how we achieve health equity and to really talk about health parity for all of our communities. So now that I've set some background on that, I just want to kind of share where we are as Wisconsin. And this is a little outdated because the new report of Wisconsin came out about a month or so ago, and it actually is not much better. But I just wanted to pull a few things out about the health of Wisconsin and look at our grades are looking good for majority populations. But when we look at our health disparity grades, we're not doing so well in the state of taking care of us. Overall health is inclusive of how we have of our dementia health in this state. And then of course, our older adult health by race. If you take a look, we look at the death rate of our older adults of African American and American Indian descent, and we are failing miserably, but we're doing well in other categories, which says we actually have the opportunity to improve and that we can do something. If we can get it right in one group, we certainly can get it right in other groups. And then this last slide, I believe this is the last slide I want to share with you around the report card. What I want to share here specifically is take a look at those red flags around the male adult age 65 and older health outcomes. If you look at that flag on the bottom about Mississippi being the worst state, look at the comparable numbers that we have when it comes to the health of African Americans and our American Indian male population. We are doing worse than Mississippi. And that speaks volumes because we have resources here in Wisconsin that other states, and particularly Mississippi, may not have. So when you think about that, we have to talk about what are some of these policies, what are some of these barriers, what are some of these challenges that are facing our Black and Brown communities in Wisconsin that we might systemically need to address in order to improve health outcomes overall, so that we can then talk about how do we address health outcomes for our aging African American communities with Alzheimer's and dementia. And now I'm going to shift and actually talk a little bit about dementia. So when we think about dementia, and I know majority of us on the phone may be involved with Alzheimer's and dementia and know this, so bear with me. I always try to just do an overview because you never know who's not up to speed as to where many of us might be with the understanding of Alzheimer's and dementia. So we know that dementia is definitely a syndrome. It's a collection of symptoms related to cognitive decline, and it can include cognitive, behavioral, and psychological symptoms. It's certainly due to biological changes in the brain. That's really important when we're talking to communities to help them understand that Alzheimer's or dementia is a syndrome, and it is biological. It is not solely a mental health disease, as many people think. That causes confusion in our brown and Black community, thinking that it's not biological, it is something social, it is something that is a mental health challenge that people choose to do, right? We have to talk them through to show the pictures how the brain is changing and the images that they can actually see, that we can now see dementia in the brain. That's really important conversations to host with folks. Alzheimer's, of course, is the most common cause of dementia. Mixed dementia, particularly in Black communities, is very prevalent. And some causes of cognitive decline are reversible, but they're not truly dementia, which we know depression can be an example of that as well. And there's some others that we know are causes of dementia, but not leading to Alzheimer's disease. And of course, there's currently no therapies for Alzheimer's disease that can cure Alzheimer's disease. And I know there's recently some new therapies on the horizon that have been approved, but they don't cure Alzheimer's disease. And we still have conversations around that new therapy that's out right now. And so here are the traditional hallmarks of Alzheimer's disease, where we just look at the our neurons, right? We look at the tangles, the plaques and the tangles. We know that they are, again, impacting the brain. That is what we see in this picture. So we're looking at a normal brain versus an Alzheimer's brain. Again, you can see the deficit in the brain. You can see the white matter. You can see the changes to the brain that Alzheimer's makes inside those neurofibrillary tangles and within the amyloid plaques in the brain cells themselves. So I want to talk briefly about, again, getting into what are the most recent Alzheimer's facts and figures. And so I do give a shout out to the Alzheimer's Association. I sit on the board of the Alzheimer's Association and here in Wisconsin, for full disclosure. But the report this year was absolutely, or 2020's report and 2021, but this particular report is from 2020. And the information that was in this report really was, to me, quite mind-blowing, because we still know that Alzheimer's disease is the 6th leading cause of death in the US that does not have an effective cure. And it is the only one of such that is in the top 10. We know that over 16 million folks provide unpaid care for people with Alzheimer's and dementia. But one of the statistics that really struck me was that 50% of those primary care physicians believe the medical profession is still not ready for the growing number of people with Alzheimer's and other dementias. That is really important for us to understand, because again, when you think about Alzheimer's and dementia in general, if that is what we're saying about the general population, imagine what we're thinking about for those communities of color that we know have not only Alzheimer's disease, but multiple other chronic diseases and conditions that will further complicate Alzheimer's disease. And so we're concerned of how we're going to make sure we're addressing communities of color around Alzheimer's disease. And so our prevalence in the state, again, 65 and older with Alzheimer's disease. Right now, we have a total of 120,000 with the expectation of an 8.3% increase to about 130 by 2025. That is less than 5 years from now, right? Because we're in 2021, almost 22. Can you believe that? So we still know the numbers are growing, and we still have to start talking about how are we going to address not only dementia in our state, but the growth expectation of people of color that we know will age with dementia. What are we going to do to understand how we're going to serve them and treat them better? So what's the real deal? What's the skinny? And this is probably what you guys are saying. What is what I came for, Gina? Let's talk a little bit about this. What's really going on with Black folks and dementia? So the prevalence of Alzheimer's disease is saying that roughly African Americans are roughly double or 2 times more than our non-Hispanic white counterparts to develop some form of dementia or Alzheimer's disease. And why is this an important number to know? Again, as we expect the number of African Americans to continue to grow with Alzheimer's disease, Alzheimer's is not going to grow by itself. Those community members will also have other chronic conditions and illnesses. We know that African Americans, if you remember that total health concept map that I showed you, that's why I showed you that map, because it's saying that as African Americans, we can't solely concentrate on Alzheimer's disease because we have so many other risk factors that are not only contributing to our Alzheimer's disease, but it will complicate the Alzheimer's disease. It will complicate us getting a good diagnosis. It will complicate us in just life in general. When we think about diabetes, when we think about chronic heart disease, when we think about how all of those actually impact our day-to-day living, when it impacts the cost of healthcare, when we think about that as people of color, those are things that are complicating how Black people are actually living with Alzheimer's disease. Because again, it's more than just getting a diagnosis, it's actually discussing how are we going to live with this disease through our families? How are we going to decide who's going to caregive? Who can be caregivers? And what does that really mean? Who's going to be our care providers? Where are they going to be located? How is transportation going to be obtained for us to get to and from appointments? Because oftentimes there's not care providers in our specific communities, especially if we're in a very urban setting. So we have to be mindful that this prevalence of saying double means also, how do we double our care? How do we double our access for people of color to now navigate these systems? So what are some of the impacts of Alzheimer's disease on communities of color? Well, we know that African Americans, we consider dementia and Alzheimer's a public health crisis in the Black community. And why do we consider it that? Quite frankly, the underdiagnosing that happens in the Black community is really high. And not only not being diagnosed, but then treatment. Black folks are less likely to get diagnosed early on in early stages, and then they're less likely to be treated. All of that, again, renders the cost of care up. It causes stress on the families, and then it also causes stress on community members, as well as just our care system as a whole, and just families as a whole as well, not to mention the person who has been diagnosed with dementia. We know for sure we really need to work at getting better treatment options for our community members that are of color. Many of them do not get, the current treatments that are out there are not either designed for them or they just have not been prescribed. And some of that has to do with lack of trust of healthcare systems, which I'll talk a little bit about as I continue in the presentation. I'm going to share with you some of the things that the community has said, but because of that lack of diagnosis, that increases burden of stress on families. That actually causes more family challenges, family disruptions, and really costs the family financially because they're trying to make up for either a lack of diagnosis or just not really trying to, or failure to understand what the implications of dementia really means to their loved ones. And again, when you think about the undiagnosing of Alzheimer's, as I said earlier, it will complicate the management of other comorbid conditions. So I'll give you a quick example. There was a gentleman on one of our staff's caseloads who, prior to being diagnosed with dementia, had a provider who had diabetes, and he was forgetting to take his medicine. And of course, we all know what happens when you don't take your insulin. It further complicates the diabetes. And, the doctor was thinking this person was simply, not willing to comply, wasn't uncompliant, and just was intentionally not being a good patient, as they described. But what happened with the advocacy that was happening through our care manager on our team, we were able to talk that provider through and say, have we thought about maybe there's some memory issues here? We talked with the family, we started understanding better what the family was seeing, which they were seeing forgetfulness. They were noticing notes in the house. They were noticing that this person was not taking good care of himself through hygiene. They noticed all of these things that were happening, but did not necessarily think it was dementia. They would talk to the provider and say, we're noticing things, but never went that last mile because the provider and the family didn't necessarily have the opportunity to have that collective conversation. Once this person, got the care and support that they needed through, first of all, getting a good diagnosis, circumstances changed. We were able to help this person develop a plan with his family, how to make sure he was managing they were helping him to manage his diabetes, right? And the provider was able to now see changes on the positive swing, right? So undiagnosed or not being diagnosed actually complicates management of chronic conditions. And again, this is important when we're thinking about it from a perspective of an African American, because those family members also did not trust the healthcare system. And so as a result of that, there was just these complications that continued on. And so we think about it, majority of healthcare provided by unpaid care, informal caregivers, as I described. Most Black women are daughters and mothers and employees, and they're still trying to take care of their caregivers. That impacts care overall. And there's data out there, the research shows that African Americans who are caregivers for loved ones with Alzheimer's and dementia, quite frankly, have higher stress levels, but they actually don't resonate with their stress. So they don't even identify their stress with being a caregiver. Part of that is they don't call themselves caregivers. It's my dutiful duty to take care of my family member, which then actually causes disruption in families. It also causes, while I'm not depressed per se, I have things like I just don't feel well. I feel like I have the blues, right? And that actually impacts how that care is happening for that loved one. And so we also have this value and cultural belief that Alzheimer's disease it may not be real. It is something because we don't see it, we don't necessarily believe it until it manifests in the form of, let's say, a person straggling off, or a person getting lost, or the police having to be called. And then it's a crisis situation, right? And so then we're paying more attention and more attuned. And we also have to make sure that we are making sure we're respecting our elders and having dignity. And so sometimes talking about Alzheimer's disease in the Black community feels as though it's taking away from a person's dignity. And so when we think about risk factors, the Lancet did an awesome article on risk factors of dementia. And what you see before you are two different diagrams. One is risk factors and risk reductions. So when you look into the far right, maybe your left, but my right, it says risk factors from dementia. And when you look at that little mapping slope, it goes from birth to early life to midlife to late life, right? And all of the things I talked about in that first slide, with the exception of the genetics of ApoE, all of those are relevant to people having risk for dementia. So less education. Remember those social determinants of health? Midlife, we can have hypertension, obesity. Hearing loss is a risk for dementia, right? Smoking, depression, later in life, when you go down that spectrum, right? All of those, physical inactivity, are really crucial to developing Alzheimer's or dementia, a form of dementia. But what's interesting, again, if we're thinking about it from the perspective of African-American families, when we think about who has hypertension, obesity because of sedentary lifestyle, but I can't get out to walk because I don't feel safe in my community, and I'm developing Alzheimer's disease, right? Because of my other chronic health issues. Those are things we have to think about. And now what can reduce those risks? We know rich social networks reduce depression, exercise, adherence to a better diet, the Mediterranean diet, right? Education, increasing our brain cognitive. Now, what's very interesting is that at least the Barnes and all at Rush University has done several studies around these social networking. And what we have found is that exactly this: folks of African American descent have rich social networks, and though they may even develop dementia with the right social setting, their dementia does not advance as quickly as some of our non-Hispanic white counterparts. We also know that with rich social engagement, African Americans who have been diagnosed with dementia, who are continuing to be like in social groups, who are going to day programs, who really are actually living healthy lives, if you will, actually do not advance as quickly as some of their white counterparts who also have dementia. And why is that important? That's important to understand because that goes to programming, it goes to service delivery, it goes to looking at mechanisms that we might need to put in place to actually help address Alzheimer's disease in Black communities differently than we do in our Caucasian and maybe our Hispanic Latinx communities as well, but specifically our African American communities. And so does race play this huge role? Well, you know, the reality is, and Chen and all talked a little bit about race as a higher risk. Is that the case? Well, when you do all of the testing and when you start doing all the genetics, race really is not the determining factor that puts African Americans at higher risk. It really is and has been found to be some of those other social determinants of health and not the race factor. And so we're trying to identify what really is it that continues to cause African Americans to be at higher risk within those social settings, within those social determinant contexts. And then again, Dr. Barnes and her team talked about the testing. Well, you know, we use the traditional scoring and testing on the traditional models for determining if a person has Alzheimer's disease. The question is, should we do testing to test the individual, not testing him or her against other population and people, but against themselves? Are these tests biased? Are we over testing people of color and getting different results? Because we know that African Americans, even after being diagnosed with dementia, do often decline slower than our white counterparts. So is it the testing? Are we sure that African Americans are really at higher risk? Well, we know that some of the data says yes, but we also need to make sure that we're looking at the data in a richer way to hear the stories, to learn of the community, and talk about how maybe the testing that we're doing might need to be modified for respectively for these communities. Social determinants, I've talked a lot about that. We know that social determinants are impacting communities of color. And then access to care. And what does access to care mean? Access to care is more than having someone in a community that can diagnose dementia. It really is about culturally competent care that actually addresses the other issues of the whole person. And before we're getting to a diagnosis of dementia, or even after a diagnosis of dementia, how do we really respect those cultural differences and provide the best type of care so that a person who may be diagnosed with Alzheimer's disease can actually trust their provider, work with their provider, and then see better results for long-term care, safer care in the end of as they go through the journey of dementia and Alzheimer's disease. And I do want to kind of highlight real quickly the cultural diversity and aging with Dr. Peggy Dilworth. Originally did this work in early 2000s about the growth of minorities in this country and how the costs are going to be exacerbated, but has updated that work. And we also understand, as I said earlier, it's going to be a cost to the Black families. It's going to be a cost to the community. But what's really going to be important is how we look at how we develop programs, service deliveries, and models that actually can help keep African Americans in the community safer and longer, because we're living longer even with dementia. So barriers to appropriate care, why might we have these problems? Really, currently, there's only 4% of the physicians in this country are Black, and that has been since the early 70s. That has not changed. That's really an issue. And the data has shown, there's stories that show that, articles and data collection that shows that people who have providers that look like them fare better. And African Americans are no different. And they do desire to have providers that look like them. Unfortunately, that's not always the case. And that has been a barrier, quite frankly, to trust, to building new relationships, and actually getting good diagnosis and care after diagnosis. There's this implicit and unconscious bias, poor communication, communicating and expressing your feelings. I may talk with my hands, you may feel uncomfortable because that makes you feel unsafe. Well, the way you talk to me and demean me may make me feel unsafe. And therefore, as a person who is African American, I don't go to the doctor right away. I take all these, different venues and avenues that I know I need to go to the doctor because I have this disease or I have these concerns, but I don't feel comfortable. So that actually impedes upon my health and my can exacerbate me in my walk with dementia. So we know that as a caregiver, if I don't like the doctor, if I can't talk to the doctor, I'm not going to take my loved one there. That impacts the level of care that people with dementia may receive. And then there's also, I'll just skip to the absence of cultural training to healthcare providers. And we all know what that means. And so basically, we're trying to build these culturally inclusive programs for healthcare providers to see the world through another lens, not changing what they've learned and practiced, but really understanding they need to open up some of their thoughts around how they perceive what they think African American with dementia or just chronic health issues, why they have those health issues, and how they can be better providers for them. So when we think about African Americans, again, thinking about Alzheimer's disease, access to health insurance is really important. And we have some of the lowest numbers of access to healthcare, whether it's private insurance or public insurance in this country. And then, of course, social class in dementia is really important as well. And when you take a look at this slide, this was a really important slide for me as well. When I think about when you look at the low SES group and the downward SES group, you think about how, and then the upward low education SES group, look at where they fall, even as social class with dementia. They tend to, after diagnosis, their survival rates go down and they tend to have poor quality of life. Well, if you think about this again, the low education that I talked about in African American communities is real. And when we think about the lower socioeconomic status, then you understand why African Americans may have, again, attributing this to their advancing in dementia more, as well as having, more challenging times with Alzheimer's and dementia. More challenges, I should say, with Alzheimer's and dementia. And so I'm going to jump real fast because I didn't realize I was talking so much because I'm going to make sure I get to some of the other things I want to share. But when we think about the 2021 facts and figure, what I want you to highlight on this slide, and this is the bulk of what I'm going to continue my presentation with at this point, I'm going to transition and talk with you about what are Black folks saying about Alzheimer's and why, and their care levels, and why they may not be accessing services. So the barrier to Alzheimer's disease and dementia care, they did, these populations reported discrimination in seeking care. The Alzheimer's Association did a fabulous report that I'm going to talk about from here on out about what is it about the care model that is impacting Black folks and actually Native Americans, brown folks, and they did include lower income white communities, but I'm talking about Black communities now, from actually getting care services with dementia. And then I won't talk about unequal treatment right now, but this was a really good book if you're interested. It talks about how treatment and care is unequal in communities and how research shows that. But it's time to shift the paradigm. It's time to listen to communities of color. It's time to give stories. It's time to change how we care for people of color when we're thinking about this Alzheimer's journey that we're going to have to take with our families for years to come. So as I said before, the Alzheimer's Association had presented an attitudes work or paper about from ethnic backgrounds. And they did this survey and they, from their disease and facts and figures report, and they actually took the time to ask people how they viewed their care, their providers, etc. And so what they found, which was to me just groundbreaking and heartbreaking at the same time, more than 1/3 of Black Americans and nearly 1/5 of Hispanic Americans believes discrimination is a barrier to receiving Alzheimer's care And even half or more of non-white caregivers say they've experienced discrimination when navigating healthcare systems for their care recipient. When you think about this number, that is a really large number of people who should be accessing care but feel discriminated against when navigating healthcare settings for their care recipient, or the person with dementia feels as though they've been discriminated against. This is a blockage and a barrier to actually getting good care for people, particularly Black people with Alzheimer's disease. And then I want to share with you, again, some more findings. 2/3, almost 66% of the folks in this survey believes it's harder for them to get excellent care for Alzheimer's disease and other dementias. And then when you look at the next one, it says nearly 2/3 of Black Americans believe medical research is biased against people of color. And then finally, fewer than half of Blacks feel confident that they have access to providers who understand their ethnic and racial background and experiences. What that says in this nutshell, again, when you ask the question about quality of care, when you ask accessibility, it's not enough to say we have these clinics in these urban communities. It's not enough to say that we have these research opportunities for people of color in, we're bringing investigators here, or we're going to present these opportunities. What we have to do is make sure that they are ethnically diverse. We have to make sure that they are culturally confident. Now, I don't say competent, I say confident. And the difference between competence and confidence is when someone has cultural confidence, they have enough information to engage, to resource, to be a part of an intellectual exchange of conversation, meeting people where they are. When you talk about competence, people believe they have heard this once and they've mastered it and they don't need to do it again. Those are very different conversations and different levels of care that we know we need to actually invoke with our Black community, as well as other communities of color. Finally, we talk about discrimination in healthcare settings. Again, if half of Black Americans report experiencing discrimination, who's going to go back to those providers? You're thinking about, well, if I'm going to that provider, am I going to open up? Am I going to trust? Am I going to ask questions? Am I going to get the best possible care that I can if I don't trust a provider? So what we know is that oftentimes people who are African American go to their doctors when they need to, but they don't ask the questions that need to be asked because they don't think they're going to be heard, which in turn impacts how they behave at home, how the care provider is able to help them, because I'm not getting good information. Let's say I'm not getting information that I need in order to access the Alzheimer's Association. I don't get the information I need to access the Department of Aging, the Alzheimer's Institute, because I'm not asking those questions, because I just need to do what we need to do. We need to do blood work, we need to do X, Y, Z, and we need to get out of here because we feel like you don't care about us, because you're not going to serve us anyway. What's the point? What's the use? We need to help understand that happens daily, and again, impacts the care and how we actually are serviced. And then it actually impacts that health of not only that person on the dementia journey, but their caretaker and that family. And so I'm going to skip this slide, but I want to talk a little bit about, here is something that I think is really important, and that is the role of chronic stressors and health disparity among ethnic groups. And again, keep in mind when we're thinking about how Black folks are impacted by dementia and Alzheimer's disease, what I want to take you to in this one is allostatic load. When you think about, we know that is a contributor to inflammation in the brain and inflammatory and autoimmune disorders and cognitive impairment. All of that is related And when we know that high level of stress is impacting African Americans at an alarming rate, not the normal stress that you and I might have or that people may have, but this is chronic stress, ongoing stress is something that Black folks experience on a day-to-day basis because of systemic racism. And we know that this has been proven and written by, as you see, many authors. And so I think that is something to think about when we are wondering, how is Alzheimer's impacting Black communities? And then finally, stress and premature age in the immune system, of course, will enhance the risk of illness as well as age-related diseases, meaning Alzheimer's disease as well. And so we know we've been impacted as Black folks by hypertension and diabetes due to chronic stress resulting from discrimination. All of those play a role in Black people in Alzheimer's and dementia. And it plays a role to the point of continuing to, in our early years, carrying these allostatic loads, carrying this stress over years of time, and then developing a form of dementia. Again, it is reasons perhaps why we're developing dementia at a more alarming rate.
Gina, can I interrupt real quick? We had a
Yes.
question.
Mhm.
They asked, can you tell us more specifically how they feel discriminated?
Yes, I can talk about that. So how do people of color feel discriminated against? And so when people have talked about going to their providers, and when you walk into let's say you walk into the front door, you may come in and you may not look like the people in the room. And then there is an assumption made that you're either a public assistant, or you may ask a question that is specific to your situation, but the answer is met with a condescending response. Or it may be, I don't know where I should go. Can you help me? And the answer is, we don't have any help for you. We don't know what to tell you. We also know that there are ways in which, again, opportunities for treatment opportunities that are not offered to Black patients, simply because providers may feel as though they won't participate they're not asked, but they won't participate, or they feel as though they're not designed for them specifically. So access to opportunities is something that we're discriminated against. Patients are feeling discriminated against when they are looking for conversations, for instance, with the caretaker to say, I'm noticing A, B, C, and D, and then they're blown off. They're not addressed. They are, oh, that's normal. Don't worry about it. If you ask for testing, you may be declined testing. I know there's a lot of people who have said to us, we've asked for mom to be tested, and we've been told point blank, no, they don't need that. They're aging. They're supposed to have memory loss. Not recognizing that it's not normal memory issues, right? Again, there's discrimination from where they're being sent for. Let's say you got to go see a neurologist. They might not be sent to the best neurologist. They'll be sent to someone who's adequate, but not the best. Those are ways in which community members have felt discriminated against. Does that help?
They said, thank you.
Mm-hmm. So what can we do better? According to Dr. Barnes and Dr. Chen and all of these wonderful educators and researchers, community engagement is critical. Community engagement means getting out of our four walls and ivory towers to actually learn the strengths of the community, learn what the community does well, help learn about the values of the community, engage them in conversation, work with your patients about how to have care treatment programs with them, not for them. Diversity, inclusion, and education, right? Equity and inclusion education is really important. Understanding how organizations can become more diverse. So for instance, making sure that team members are from diverse backgrounds. And when you walk into an environment in a doctor's office that is not sterile, meaning that it does actually speak diversity, that it has pictures of diverse communities, that it has welcoming of diverse tones. It actually has conversations with people about diverse things, and actually not streamlining everything to believe that all of the providers are Caucasian, or all of the research is done by people who are not of color, but actually celebrating equity, celebrating the whole issue of diversity, improving access to care, making sure that care opportunities are not so far away that people cannot get to them. Also, when they do come to have your care, make sure that it's something that, it is accessible, not just, and I don't just mean wheelchair accessible, I mean really making sure that people feel welcome in your space, and that by access, making sure that the providers understand what are some of the, maybe some of the challenges it took to get there. So for instance, I'll give you a really good example. Many offices have a 15-minute rule. You need to be within your appointment within 15 minutes. Well, if I'm using public care transportation, which made me late by 20 minutes, and I don't have any control over that, and you tell me I can't be seen at that visit, now you have just, disrupted my access to care. I can't control that. Think about having more accessibility. Think about having modifications to your time limits, especially when you're talking about people who are using public transportation, people who worked hard to get there. They spent, your care providers who are daughters and husbands and wives of their loved ones who are bringing them to your services, and they are late, but it took them 4 hours to get prepared, and then they're 15 minutes late, and you say, oh no, you need to come back later. Think that through. Let's talk about how do we open our thinking, our processes, our systems to actually address how can we improve access, and I know we have time constraints, but how do we address the access issues for these caretakers and for these folks on the journey? And addressing the systemic barriers to equity, improve and revise our AD testing, as Dr. Barnes talked about. We need to look at the actual testing that we're doing to get past the mini mental status, or just, all of the ones that we're doing, that the longer, instruments that we're utilizing, are they the right ones for Black communities? Should we measure behavior over time? Should we measure individuals against themselves? How do we make sure that we're using the right testing? Is MOCA really the right test for the Black community? I know a lot of people use MOCA in Black communities, but is that the right test for the Black community? I'm not saying it's not. I'm not saying it is. I'm saying we need to think it through and ask these questions. We need to also have more inclusive studies for people of color. We need to have studies for people without dementia, Black people who don't have dementia. We need to really improve those studies, and then including Black people in studies up front, which means we might have to change some of our criteria. And then finally, having resilience models. And by resilience models, what we mean is that we really need to look at and think about how do we actually look at who survived this dementia in Black communities. How have Black families been surviving and thriving, not just surviving, but thriving through dementia? And talk about how do we create these models? Who's accessed services through the Alzheimer's Association well? What worked for them? What models of the association work well? What models at the Department on Aging and the Center on Aging work well? How do we bring these templates into our larger scope so that we can help more of these families have success stories? How do we reduce burnout with resilience models? Because there are folks who have utilized services that and have had family members with dementia, that they've created these internal family structures that have worked for them, but we don't accept them in the general community. How do we talk about that? And what do we do to further advance that work? And then I just will end. I think I'm out of time. You can tell me if I can't see anyone because I've got my screen minimized, but how much, Laura, am I out of time here? I've got one more slide, but I can certainly
go ahead and
here.
keep going. We have 30 minutes built in for
perfect.
Q&A, so.
Okay, perfect. I'm going to do this slide. I wanted to bring to your attention, I know I've probably not talked about, most people want to hear, something defined, I think, about specific African American, what works. So I'm going to share with you what works. So we have 2 clinics specifically in Milwaukee. I know we have the Diagnostic Memory Clinic, which many of you are familiar with across the state. But I want to talk about 2 of our ethnic specific dementia memory clinics, which are really phenomenal. Our memory clinics are awesome, by the way, through the Wisconsin Alzheimer's Institute, and they are designed specifically to help people get a diagnosis and help nurses and practitioners and physicians really care for patients using a really important, I say, just strength-based model. But I want the memory clinics that are 2 ethnic specific. Milwaukee Health Services Incorporated is a federally qualified health center right in the heart of Milwaukee. And it focuses specifically on African Americans. And then United Community Center, many of you may have heard of it, is on our Latino and Latinx community and Hispanic side of town. And both of these memory clinic models are really important because they actually take into consideration, if you notice, the patient first. And what I mean by that, they have actually developed these clinic models specifically for African American and Latino communities. And what we have done is we've created this patient referral system that actually starts with physicians, social service agencies, and behavioral health community members. And we actually have staff members, and this is both clinics, staff members who work with the providers of these clinics to actually work with families directly to make sure they get a good diagnostic testing, they get a good diagnosis, they collect data and information on these family members, and then the care doesn't stop there. The care actually continues on to the other side of the support that builds for these families to feel supported. And what I mean by that is we have care management follow-up services. We have a social work care coordinator. We have a nurse practitioner, community health worker that actually follows and works alongside these families so that when their loved one has, whether new office visits, whether there's a change in their dementia stage, whether there is a social need or a social supportive need, such as food, such as housing, transportation, we provide these care management follow-up services, whether the senior's living in a senior high-rise or a private residence. We go into those homes. We continue to do the caregiver burden stress surveys. We continue to build these networks for these families so that they can actually keep their loved ones home safer and longer. And that has been really supportive of that loved one. Remember, I think early in the slides when I shared with you that people, African Americans in particular, with supportive services and with high social functioning opportunities and high social engagement can live longer with dementia and actually do fare better with their dementia. And so we know putting this care continuum model together has helped engage and support these families over time. And we have gotten reports back that the data shows that these families do well and really appreciate this ongoing support. And the last item on there, what you'll see is the research. We know research is critical to our work, but we don't, if you notice in this wheel, we don't ask people to participate in research first. That is the last thing on our mind. We're trying to help families be sustained. We're trying to make sure that Black families in particular are getting the care they need, the support they need. And then if they are interested, we offer them research opportunities. And I can tell you that because of our model, we have gotten research opportunities. Here's our diagnostic clinic network. Again, these are the ones around the Milwaukee area. I certainly know there are 44 across the state of Wisconsin. I can get them the information to you. Many of you probably already know about our diagnostic memory clinics, but we certainly can get that information to you. But I wanted to highlight for you that it's going to take us really being intentional about having ethnic specific opportunities to continue to have this growth and supportive services to help our folks actually stay in the homes healthier and for longer periods of time. And then I will actually just end here by saying, we know that African Americans are underrepresented in research. I would be remiss if I didn't talk about the importance of research in our community. I will just share with you, our RAP program has introduced a really important component of asset-based community development for people who we know are interested in research. And because of that, we've been able to increase our African-American participation in research from a 2% to now about 13% or so. I won't belabor that, but I will share, if you're interested, I can give you program highlights about how we've done our research recruitment, but it has significantly changed. We came out of clinics and actually went into community and developed this model that has really helped us identify Black families who have had a loved one with dementia, and how we can support them. We do this wraparound support with them, and then we actually help build bridges to asking them to participate in our research work. But I will definitely end there and say thank you. My last phrase is go to the people, live with them, learn from them, love them, start with what they know, build with what they have. But of the best of leaders, when the work is done, the task is accomplished. The people will say, we have done this ourselves. So thank you for having me today. I hope I've said something that has been useful and practical, and that you have gotten something out of this work.
So I have made it so people can unmute themselves. So it's great to have dialogue if anyone wants to unmute and ask questions. Otherwise, we also have the Q&A or the chat. So thank you so much, Gina. This was helpful.
Hey, Gina, this is Trisha. I'm the one who asked the question earlier. Question with the African Americans going into becoming physicians, is there any efforts or initiatives to increase that number?
So yes, they're actually, interestingly enough, all of the universities and institutions have these new programs that are pathway programs for to increase the number of African American providers across the systems. What's interesting though is that despite some of those efforts, I think the challenges come when it's time to take some of those MCATs, when it is time to really identify a clear pathway where we address those system biases that prohibit us from actually getting to the enrollment piece of African Americans. Once a student is enrolled, then yes, they are well taken care of. The challenge is getting them to the point where they can actually become enrolled in the institutions to become doctors, physicians in specific. And so that's been a challenge that I know many have taken on, but I know there's pipeline programs across the country. There's several pipeline programs here in Wisconsin. Actually, Medical College of Wisconsin has them, UW-Madison has them. But it's really disappointing that we don't see the increase in Black physicians the way we would like to.
Thank you.
Mm-hmm.
I have a question. I'm not sure if you'll have an answer for it, but we would love to get connected with the African American community here in Green Bay. And we're just curious if you have any thoughts or ideas of the best way to go about that. Of course, we're warm and welcoming, yet do you feel that going to where they are might be a next step versus inviting them to us all the time? I don't get a lot of referrals from that community. So I'm just curious if you have some insight as to why that is and things I could do to improve that.
Sure. I think there's and again, not being in Green Bay, I don't know, but there's a couple things. I think if you are willing to, community engagement, for instance, looking at what your community engagement strategy is, I think oftentimes we have to have a real clear strategy, meaning we need to bring our teams together and say, how comfortable are we at going to family reunions? How comfortable are we at going to churches, to church picnics, to places where we know Black people congregate, and not just Black people, but brown people who congregate. We do, to your point, have to get out of our comfort zone and asking them to come to us. We need to figure out where they are and meet them there. But we also have to go with the mindset of learning from our community. So And what do I mean by that? Oftentimes we go, we offer what we share what we have to offer as organizations. Sometimes it's just going, what we did the first 18 months, we went into community and we didn't say anything. We learned from community. And when they asked us why we were there, we said, we're here to learn from you. We're here to not take anything. We're here to give and give our time. We're here to understand your processes better. We're here to recognize who you are. What strengths do you have? And then we can build our strength with your strengths. What are the questions that you have about, you know, I think it's interesting because Black communities and Brown communities, we don't always want to just start talking about Alzheimer's disease. We want to talk about our lives, right? Our lives are not consumed by Alzheimer's disease. Our lives are consumed by our health overall. And that's why I try to, you know, I used to do presentations all the time about go in the community and talk about dementia, but that's what people went in the community and did. You have to go into the community and say, no, I don't want to talk about dementia. We want to talk about what you want to talk about. If that's diabetes, then we need to figure out how to talk about diabetes with you. If that is chronic heart disease, we need to talk about heart disease. And that's where you start. You meet people where they are. You need to find out what people are calling dementia. Some people aren't calling it dementia. They may just be calling it, you know, mind loss. They may be, I don't know. But we knew in Milwaukee, people did not want to hear the word Alzheimer's disease. They did not. The Black community was like, I don't want to talk about that. But they were willing to talk about memory loss. They were willing to talk about, you know, forgetfulness. They were willing to talk about, you know, changes in thought. So we had to meet people where they are. But the only way to do that is to go, sit, listen, and then become think partners together. The other thing I would encourage you to do is, as you're trying to address Black communities, maybe think of having community advisory boards with Black people and actually having them lead your discussions. Teach them, bring them professional providers to come and train them to understand about, one, health overall, two, what is chronic illness, right? Many of us live with chronic illness, but do we understand that definition? And are we using a shared language? It's all about sharing this dialogue and this relationship building. That's what you're doing so that they can trust you. You can trust them. You can learn from each other. You're not just throwing your information onto them, and you're letting them know that, guess what? When I come out of my office, I'm no longer the expert, but you are. And so what I'm trying to do is contribute to that. So yeah, that was a long-winded answer, but.
Love it. Thank you so much.
Hey, Gina, this is Trisha. That was actually really good. So in Barron County, I'm working with a community health worker for our Somali population, targeting just right Alzheimer's and dementia, you know, education. And we've had a meeting with the elders, but Noah is a really good reminder of like, what do you, and it was interesting because they brought up a lot about like sleep apnea, and like diabetes and some of the other stuff that's what they kind of wanted to talk about. So no, I really appreciate that statement, is like starting with where they want to talk about and go. I mean, I did learn a lot from them in that, but it's also been helpful having a community health worker who knows that culture that can also help me. Like you said, I don't feel very confident in the Somali community, but I want to. And so having that somebody that's connected to both worlds has been helpful.
Yeah, I think, Trisha, you're right. And I think and then you know what? It's okay to say, I don't know. It's okay to say we're all new and be new and say we're really wanting to learn from you, especially a culture that, you know, Somali culture is different than Black culture. And so you can't take the same cookie cutter approach anywhere. It's really about saying to the Somali community, hey, you know, tell me about mosque. I don't really understand, you know, how you worship, but I know that's important to you. Worship goes with diet. And I don't know sleep apnea, but I can bring someone here because it may be prevalent in their community. And so they're asking you things that they know are prevalent in their community, and they are attributable to diabetes, to dementia. And diabetes, as we know, is definitely attributable to diabetes, to dementia. So asking them, when they ask you for something, being able to say, okay, let's start with that. And then the more you release and ask and agree that you don't know, but you're bringing information, the more they will release and share information with you and actually start asking you questions. And that's when you know, when the tables turn, when people start asking you questions, you know that you've gotten to a point of there's some level of trust there. And I do apologize for not talking about that more in detail. I certainly have those slides too, but it really is about building that reciprocal trust, because you've got to trust them and they've got to trust you. Oftentimes we just think, well, they got to, we got to get their trust. No, you got to learn to trust the community too, because that's not what we're brought to do. We're brought in to be experts, right? Well, I have to say I'm vulnerable in the community because I'm not the expert. I'm not, and that's okay.
Ooh, that's good. Preach. I like it. Good stuff.
We have about 10 minutes left if anyone else has questions or thoughts or comments.
Sorry, since I feel like I'm overtaking everyone, but since you're with me, Gina, one of the comments that you had said was the providers being really dismissive. And I see that a lot in my rural areas too, even with working with care partners to call the doctor ahead of time and share concerns. I've had a few providers that said, no, you can't do that. Well, yeah, you can, you can tell the doctor your concerns. They may not be able to tell you anything back, but dismissing it as, oh, I don't need to do a memory screen with you. And I've heard this because you're dressed to the nines. There's no way there could be anything wrong type thing. And so I just feel that that's pretty all across the board, regardless of color, but definitely at least I see that a lot in our 3 counties, very dismissive of not all the doctors, but there are definitely, it's getting better, but there's definitely a lot that still it's very dismissive of that. So probably going back to that 50% of primary providers are not prepared to handle the upcoming wave.
Yeah, that's pretty scary number there. And I think to your point, Tricia, so discrimination doesn't discriminate against race. It builds on race, to be honest. And I think what we do know is that, as African Americans, we're talking about being discriminated against simply, because it's in that moment, right? And I think what happens is that when, you can tell me no once, but every time I ask for something, you're telling me no over and over and over. Well, then that does feel like discrimination. That feels as if I am not getting something that I need from you. And you're simply telling me no because it's me, right? It's not processed. You're not explaining it to me. You're not telling me it's something, beyond your scope. You're just telling me, no, it's not doable. And I think it's very interesting that, providers, even in their own, again, insecurities perhaps, but they're taught to be the person in the room with the most information. And so even think about this, and I'm sure this happens to everyone on this call, that you can go in and ask a provider for information. And if you ask for too much information, well, then they start looking at you kind of side eye, like, why are you questioning me? Are you questioning my abilities? What makes you ask me these questions? And when you start saying it's my health, we should be doing this together, it's almost as though, who's the provider here, me or you, right? And those things actually can impede upon us being advocates for ourselves. If to the comment in the chat, if we're not a badass, right? If we're not going to do it ourselves, but we have to force those things. And so I think it's really finding that delicate dance with providers to say, I'm not trying to tell you how to do your job, but I have been in my body for, I don't know, since inception. So do understand that I do actually understand some things about my body, right? So when I say to my physician, I know my memory's changing and you're telling me, no, oh, don't worry about it. It's just normal. No, this is not normal. And then you're blowing me off consistently, then yeah, it's like, why are you doing that to me? But I think when people are, just again, looked at odd or funny because you are just different, you don't know what you're talking about, or again, discriminated against to, I won't refer you to that person because, or I won't make this referral because you're not going to comply. That's discrimination. It's like, how do you know? Or simply because you just don't think I should get it. You should get this, right? That's a problem. And I think unfortunately, we've experienced discrimination for so long that sometimes something that is just, to your point, Tricia, across the board feels like it's just being done to me. And we have to understand that might not be the sole case. So I do have a question for the audience. I mean, so I talked a little bit, I know I talked very broad, but I would love to hear your questions about what I didn't talk about that you really, really might have wanted to hear. I'm certain I could probably talk about it, but I will be very honest, being on the COVID hiatus, I've tried to freshen up some of my talks because I'm like, I got to figure out the bigger scope and where people are, because things have just changed so much. So I'm happy to talk about things I normally would have talked about. So if there's something burning that I missed that you wonder if I know, there's probably, yes, I do know. I'm happy to answer that question for you or talk about it.
Gina, I have a question. You were talking about, we talked about advocating for yourself, but in a culture where you've been beat down so much to where you just give up, how do we best help? Is it better if we try to work the system to help set it up better? I mean, it's kind of, it feels overwhelming in a way. How do we like fix it so that Black individuals can feel more comfortable coming into the setting? So a lot of us aren't directly in the healthcare, but advocating for people who have dementia. How do we best help in our communities?
Yeah, that's a really great question. I think the reality is that you do what you know you would do for someone else, right? And I think there's this myth that Black people don't want help and don't want to utilize services. I think that's a huge myth that's out there that's absolutely false. And what I think you guys can do, what you can do, particularly, you know, as a white person, as a person who cares, as a whatever, however you put, whatever role you're putting yourself in, is just being genuine and coming to that person and saying, you know, hey, I don't, you know, the biggest leveler is when you're the patient. And so what you do is you share from the perspective of saying, hey, if it were me, I wouldn't know how to navigate a system either. Because many of us on this call, until we flip that side, we have no idea what patients go through. It's only when we start going through it with our own loved ones, our own selves, that we are better advocates, that we are like, what the heck? And I know the system, right? You've said that to yourself. I can't believe how this happened to me. And I know the system. And how they going to, oh no, right? So then you see someone else, you're like, oh, wait right there. I'll call so-and-so. That's the stuff that you do with families, and you see them struggling, you stop and you say, you know what, let me handle this with you. If you would allow, you know, I would love to help you in this. And here's how I can help. I can call so-and-so, or I can do this. And you ask permission, but you really are saying, I've been there where you are, right? So it's meeting people where they're and being fragile enough to say, I don't know everything about you. I don't understand everything about you, but this thing, it's common. And I know because it's been my experience. That's when you start, you know what I mean, breaking ice and really seeing yourself in that person's shoes.
Corey had a comment that we're more than a brochure rack. Isn't that the truth?
You know, Corey, what I tell my team members is that we don't do standalone brochures. Are you serious? You know, you cannot pass a brochure along and expect people to follow it. You know, one of the largest reasons people don't, after a diagnosis, don't immediately follow up is because it's not a warm handoff. It is the handoff of a brochure. Well, here's the Alzheimer's Association. Well, I'm not calling them because you just gave me this huge diagnosis. I don't even know what that means, really. And I don't even know who to talk to there, right? It's a warm handoff. It's a, hey, you know what? I know this is tough for you. Let us contact so-and-so at the association with you. And, or do you mind if we give your number out and they'll call you? And I'll be actually on that call with them because I know it's a challenge for you. And then actually, when you notice that maybe they're getting blown off, you actually intervene in that conversation and say, you know what? I think we could do X, Y, and Z. Have you thought about this? Because you're now helping them, because we don't know what we don't know. Blind spots are just blind spots, right? Gaps are gaps. You might know the question to ask because you've been on multiple conversations. keep in mind, this is my first conversation. So what do you all do? You start saying, oh, you know what, Gina, I didn't hear you talk about X, Y, and Z to this person. What about that? What would that work? I know I've used that for so-and-so, and now I have to say their names, but for another client, what did you think about that? Because what you'll start seeing is that people will intentionally leave services off for certain groups of people. Oh, you don't want to go on that side of town. You can't get to that side of town, right? I won't even mention that to you. Oh, you don't have transportation probably. So I'm not going to ask you if you have transportation. I'm going to assume that you don't have transportation. I'm going to assume because you live on the north side, you have no desire to go to the south side. So I'm not going to recommend these options for you. That's the kind of stuff that happens.
You don't even ask, and 3 of their kids live on the south side.
Exactly, Corey. That is exactly what happens. And so we know that that's happening in the communities. And so then you wonder why they don't show up or why they don't come back, because you didn't help me do what I needed to have done. I'm sorry, Corey.
No, I agree. And I appreciate it. And I've sat in meetings with families for 2 hours and no brochures ever changed hands.
Exactly.
Because it was just hanging out and letting them get to feel that they could trust me as a person. And you know, I've had people say, you're the only person who's listened to us. You just sat there and listened to us. And it's like, that's the beginning always, is listening.
Yeah.
And I think most of the people on the call here know that.
Right.
That's what they do. And that's why we do what we do.
Right. And that's the big deal on the conversation today for me, is that, you know, I don't want to come in here and tell you what you know, because you already know what you're doing. I'm here to help you with maybe some of the facts and figures that you didn't know, maybe some of the data that you didn't understand. Most times what I've learned is that the folks on this call are probably getting it right. You're advocating. I think, you know, it's like you're trying to figure it out. And if you don't know, you're willing to ask the questions, right? You're willing to step back and say, oh no, I missed that one, but hey, Corey, this is what happened. How do I get past this, right? How do I make it better the next time? And so my job is not to come in here and tell you how to get it right, because you probably, you know, what you're doing wrong, but it's to acknowledge what you're doing right and then maybe enhance what you're doing right. But sometimes it's really also important for me now to make sure that you have the background data around why things are. So, you know, that's why I talk about how is health overall important in Alzheimer's disease, because we can get so caught up in our silo about Alzheimer's disease that we forget that these are whole people. And Alzheimer's is just one spectrum of their life. And they have to be mindful of being Black all over their lives, or they have to be mindful of their health as a whole. And so it's really important that we talk about the whole person. So I will stop there.
Hey, Gina, I have one other question. 2019, we had done a lot of memory screen outreach before COVID and stuff. And a lot of the positive screens that we had sent to the doctors with like a letter, et cetera, I would say probably, 75% of them, when I went to follow up with the person themselves, said, oh, my doctor never mentioned it. And of course they forgot. So when I went to call, I said, and I did kind of what you said, can I help with that? Let me call them and see what's going on with that and advocate. You know, most of the nurses were like, oh yeah, we received that. Oh, I guess we kind of forgot to do anything with that. Do you think it's more like, I've always wondered, is it like ageism at play more than as a type of discrimination that, well, you're just getting older and it could be that it's not taken seriously? Or is it just that the hospital systems were just too overwhelmed and there's not organization? I mean, what do you think is going on there? And I just brought that up because I know you were talking about advocacy.
Yeah, no, I think it's and in both, to be honest with you, Tricia. I think, you know, we have to recognize that our healthcare system is stretched. We have to recognize that there are boundaries, and people, quite frankly, are overwhelmed and overworked. And so, yeah, there's priorities, and then there are priorities. And so ageism is a role for sure, perhaps, but I think it really is, I would say it's overtaxing systems and overburdened with systems, which is why, to your point, you're there to advocate, to do that extra nudge and say, hey, we sent these over. We didn't see anything from them. What do you think? Are you guys going to do anything? Can you do anything about this? Right? It's that because you can do that, but remember that person can't, because they may forget to ask their doctor. And so, and even if they ask their doctor if they did nothing with it, the doctor's gonna be like, no, we never got it. So are they gonna do the investigation? Maybe not, maybe not. But the point of you calling and saying, hey, we did this and we didn't need a follow-up or so, you know, is really important because I don't know, fortunately or unfortunately, we're these middle people, right? We're these liaisons. That's who we are. We are those reminders, and that really is helpful in my mind.
So how do we advocate like for systems change within that? I mean, because
Yeah.
I'm going to run out of time if everyone starts coming up with also, you know, or having positive memory screens that nobody is taking seriously or doing anything.
So the best way I think to advocate, Trisha, is really by, and you guys are, you know, we're in different communities. So what we've done to advocate is started hosting trainings. We've started hosting information sessions. We've started building true relationships with physicians. We've created champion physicians to help us internally. Because guess what? We're not internal to those systems. But if we can identify champions who actually believe in what we're doing, believe in our messaging, we can do lunch and learns around why is it important for you to actually get back to us about screenings. We can do things to get CMEs to providers to come and just learn about, you know, Alzheimer's dementia diagnosing. We can do things that are in our scope of advocacy. Advocacy looks different for different groups of people, right? So for the patient, advocacy looks like picking up the phone. For provider advocacy, it looks like adjusting some of the trainings that they have to actually help them understand how this can actually improve their care model, how it can help have better patients, how this can actually, you know, make a difference in patients taking care of themselves, all those things, a case release, relief, right? But doing those kinds of lunch and learns around the issues that you know are burdensome, are challenging for you, and are system busters in my mind. Those are ways we can do that. Does that
Great.
make sense?
Yes, thank you.
Mm-hmm.
Thank you so much, Gina. It looks like we've run out of time. We'll have to have you come back. You have so much to share. We appreciate that. I put in the chat box a evaluation link. It's also a link if you would like continuing education attendance credit. You can fill that out. And Sherry, I just saw your hand go up. Was that a clapping?
You're right.
talk?
It was an attempt at a clap.
Okay.
It says clap, but I think it just froze. And I'm like, oh no, I don't have a question. I just wanted to be like, yay, and thank you so much. And that was wonderful.
Thank you.
I think we all appreciate it. Thank you. And I don't know, I can leave it open a little longer if Gina has time and people want to ask her a few more questions. I don't know if you have time.
I've got a few more minutes. If people have a question or two, I can do that. Otherwise, I'm happy to let you guys go back to your regular lives and have free time or something. It's been great though. I appreciate this. And again, I hope I've said something to pique interest and to actually help inform you and take you to another level of the work that we do.
Thank you.
All right.
Real claps work better.
Thanks, everyone. All right. You guys have a great day.
I removed the phone. Let me